Hello friends. I'll be talking on this update on acute coronary syndrome. So this talk I gave it in Coimbatore in one of the cardiac meet on 29th September, 2024. I wish to acknowledge my colleague, Dr. Megha, who helped me develop this content. So this talk, as you know, is a domain predominantly of a cardiologist. So when a topic of this nature, you have to deliberate what is new in ACS. So as intensivists, we need to look into the latest guidelines as to what is new, and any guidelines come as a levels of recommendation. So the newest sort of a guideline that is come as to management of ACS is come from European Society of Cardiology in the European Heart Journal in 2023. So this is the latest. So obviously there would be American guidelines that will come up, and that's a little older one that has been there. So we will try to touch about what is new with regards to this ACS that is largely agreed upon by the European Society of Cardiology. So this is the reference for the talk that I'll be giving. It's a 2023 European Society of Cardiology guidelines for acute coronary syndrome. So the whole topic will focus more on the management of acute coronary syndrome, what is largely accepted and what intensivists should know. So in this, they have looked at, when you talk about ACS, they have used it as an acronym. So A stands for abnormal ECG, and C stands for clinical context, and S stands for whether the patient is stable or unstable. So this is the sort of acronym that they have devised in this particular article. And when you look at the whole pathophysiology of ACS, which obviously most of you would know by now, there is an atheromatous plaque here, which gets fractured or ruptured due to inflammatory changes that happens and neovascularization, and that leads to, that acts as a nidus for the clotting activation that gets triggered, and a clot forms, and then it occludes the vessel. So this is something which I'm sure all of you intuitively know as to why acute coronary syndrome happens. When there is a clot formation that happens at the site of atheromatous plaque, when there is an inflammatory process which has led to the cracks within the plaque and the clot formation and occlusion. So this is the pathophysiological understanding as to why ACS happens. So when we talk about ACS broadly, there are different dimensions of ACS. So we have unstable angina, then we have ST elevation MI, and then you have non-ST elevation MI. So what do we understand? So in unstable angina, as you see, so this is the myocardium. There is no necrosis of the myocardium that you would see in unstable angina. Pretty much the myocardium is pretty much preserved, and there is no sort of injury or myocardial dysfunction that has happened in unstable angina. And when you look at non-STEMI, that's just the white thing I've indicated to make it more evident. There is partial necrosis. So there is injury to the myocardium, and there is partial necrosis of the myocardium that has happened. And what most of us would be worried is ST elevation MI. So what happens in ST elevation? There is a full thickness of the myocardium which gets affected. There is a transmural necrosis that tends to happen. And obviously, this is a situation where one has to emergently act and do appropriate measures to take them through the process. So this is our understanding when we talk about ACS. It can be unstable angina, it can be non-STEMI, or it can be STEMI. So when you have a patient with any of the spectrum of the ACS, the first thought that should come is think invasive. So one has to look at the invasive management. So if it is STEMI, intuitively, you know, it is straightforward that percutaneous intervention by opening up the vessel and putting in the stent is the way to go. But for any reason, there is some contraindication, or if there is no facility for doing a percutaneous intervention, then one has to resort to fibrinolysis and administer fibrinolytic agent to lyse the clot and maintain the patency of the vessel. So this is in a situation where there is inability to do the percutaneous intervention. So if it is very high risk, non-ST elevation acute coronary syndrome, so the approach would be similar, that one has to look at a percutaneous intervention to establish the blood flow and open up the coronaries. And if it is high risk non-ST elevation ACS, at least there should be a drive or a thought to do angiographic intervention within 24 hours of the event. So even if it is unstable angina, non-ST elevation, the resolve and the intent should be to perform angiographic evaluation within 24 hours is what is largely agreed upon. And in ACS, one has to, once you have done invasive procedures, then obviously you have to look at medical therapy, which you could broadly divide into antiplatelet therapy and anticoagulation therapy. When we talk about antiplatelet, the ones that are there in armamentarium is aspirin and P2Y12 inhibitor, which is clopidogrel, prasugrel, ticagrelor. But now in the 2023 guidelines, there is more emphasis on the P2Y12 inhibitor as opposed to the aspirin. That is something that is new and that has evolved. And with regards to anticoagulation therapy, obviously the mainstay would be low molecular weight heparin or unfractionated heparin, fondaparinux or bivalirudin. So predominantly low molecular weight heparin is considered as a standard of care pretty much. If there is heparin-induced thrombocytopenia, then you would think of fondaparinux or bivalirudin. And even after antithrombotic therapy, one has to think of revascularization as a concept. So when you're thinking of revascularization after antithrombotic therapy, you need to look at the clinical situation of the patient, take into consideration the comorbidities, because someone has a AKI, one obviously has to possibly think of weighing the risk benefit and delay percutaneous intervention, or if there is an ongoing GI bleed, there may be delay. So, but the thought of revascularization should be there, keeping the clinical condition in mind, comorbidities and disease complexity. And one has to resort to percutaneous intervention. If there is no room for percutaneous, then one has to look at CABG or surgery to establish the flows. And one has to aim for complete revascularization by doing appropriate percutaneous intervention. And there is a consensus that adjunctive tests to facilitate good revascularization by using IVUS, which is intravascular ultrasound, where you try to visualize the intima of the vessel, as you see in this figure pictorially. So there is an intima, there is a media and adventitia. One looks at and to establish the flows and to have more clarity on the feasibility of percutaneous intervention or dilatation of the vessel could be achieved by doing intravascular ultrasound. So this is an ultrasound probe sitting in the vessel where you tend to visualize the intima thickness, media thickness, and adventitia, and so on and so forth. So this is the sort of a rough approach. And when we talk about ACS spectrum, so you have different spectrum. It's not like patient comes typically with a garden variety chest pain and tells us that they have ACS. Many times patient can be asymptomatic, or they can have ongoing chest pain, or sometimes the chest pain can come and go, or there can be persistent presence of the chest pain. Or in ICU, where we deal with ACS, many times they come with heart failure, or they come with cardiogenic shock, or very often we see post-cardiac arrest or cardiac arrest. So this is a wide spectrum how the ACS presents. They can come from, on one end, there can be asymptomatic, on the other end, they can come with cardiac arrest. So we can see any of this. In ICU, pretty much we see someone coming with cardiogenic shock or heart failure or cardiac arrest situation. And when you look at ECGs, in asymptomatic or intermittent chest pain, ECGs can be normal, or there can be some diffuse STT depression in this spectrum. And in spectrum where there is a persistent chest pain or cardiogenic shock, heart failure, and cardiac arrest, one would expect to see ST elevation, or you can see someone having tachyarrhythmias. It could be VT or VF. So this is the sort of a typical spectrum. In ICU, when they come, we may see STT depressions, we may see ST elevation, or many times we may see tachyarrhythmias. And in this situation, when you do cardiac enzymes in any of these spectrum, not necessarily in asymptomatic patients where there are no ECG changes, the cardiac troponin or high sensitivity cardiac troponin many times may not be elevated in unstable angina. But typically, you see elevation of high sensitivity cardiac troponin or cardiac troponin, there will be a rise and then the fall, which typically happens in cardiogenic shock and ST elevation MI. And this can happen even in non-ST elevation MI. You can see rise in the cardiac troponin. So this is a snapshot or a very illustrative representation of the whole spectrum that we tend to see. So you can divide it into clinical spectrum and ECG spectrum and your cardiac biomarker spectrum, so that you have clarity that they can be in any part of the spectrum when you're dealing with ACS. So now we'll talk about what does the recommendation say from 2023 guidelines. When you look at the revised recommendation, I'll be talking about the grading of recommendation in any guidelines. You will have 1A, 1B, 1C, so on and so forth. So when I say 1A, it means strong recommendation. A stands for good level of evidence. And when I say 2A, it means it's a moderate recommendation, but in this particular guidelines, 2A means should be considered. It's not recommendation, should be considered. And when I say 2B, it means may be considered. And ABC means A is a strong evidence, and B is moderate evidence, and C is weak evidence. When I say 3, it is not recommended. So throughout this narrative of recommendations, I would be saying 1A, 1B. So when I say 1, it means recommendation. When it say 2A, it should be considered. When I say 2B, may be considered. If it is 3, not recommended. So keep that in mind. ABC is good level of evidence, B is moderate level of evidence, C is weak level of evidence. So because I won't be repeating this through them. So we'll talk about guidelines. So when there is no recurrence chest pain, when patient has a normal ECG and a normal cardiac troponin, but clinician still suspects there is possible ACS, then the recommendation, see this is, I'm showing every recommendation will be in 2 arms. What was the earlier recommendation? What is the 2023? In 2017 recommendation and 2020 recommendation of European Society of Cardiology, if there is a clinical suspicion, one should resort to CT angio, or one has to resort to non-invasive stress cardio, like radionuclide stress test is recommended. And it was, as you see, 1B, which is strongly recommended with a moderate level of evidence. In 2023, it has been downgraded. It is only, it says it should be considered or suggested. So where CT has to be done, or non-invasive radionuclide test or non-invasive stress test has to be done when there is a suspicion. So there has been a downgrading of recommendation to should be considered. And if there is a non-ST elevation MI with a new ongoing STT changes or a transient ST elevation, then early invasive strategy should be considered within 24 hours was recommended in 2020 guidelines. In 2023, it is downgraded. It says early invasive strategy less than 24 hours should be considered. So there is this small little changes that have happened. Although it said recommended, it says should be considered. But as you see, the level of evidence is strong. It's a level A evidence. So it's a good level of evidence. And 2020, P2Y12 inhibitors, which is prasugrel, ticagrelor, or clopidogrel, has to be used prior, has to be administered prior to percutaneous intervention. It says strong recommendation with a good level of evidence. And in 2023, again, that is downgraded. P2Y12 inhibitor should be given prior to percutaneous intervention, may be considered with a moderate level of evidence. So this is the changes in 2023. And as you see, the percutaneous intervention, after percutaneous intervention, 2020 suggests that dual antiplatelet therapy should be given for 3 to 6 months. And after that, aspirin could be stopped, should be considered. Stopping of aspirin should be considered was 2A and a good level of evidence. In 2023, the change is if the patient is event free for 3 to 6 months on dual antiplatelet therapy, then they have to be de-escalated to single antiplatelet therapy, and the single antiplatelet therapy is P2Y2 inhibitor, which is clopidogrel, ticagrelor, or prasugrel should be considered, and the level of recommendation is should be considered with a good level of evidence. So this is in 2023. So not much change, but there they said aspirin stopping should be considered. Here they specifically suggest that P2Y12 inhibitor is what should be used for long term and not aspirin after 3 to 6 months if patient is event free. So out of hospital cardiac arrest, if patient is hemodynamically stable with no ECG changes, then the 2020 suggested that delayed angiography should be considered. 2A, it was should be considered with a moderate level of evidence. But 2023, it says not recommended. So early angiography after a cardiac arrest in hemodynamically stable with no ST elevation, routine angiography is not recommended in 2023. So before it said it should be at least considered. Here it says you don't have to consider doing angiography when there is hemodynamic stability, when there is no ECG evidence in 2023, it's not recommended. And in out of hospital cardiac arrest, where they have there is return of spontaneous circulation and patient remain comatose, so targeted temperature management of 32 to 36 degree was indicated. There was a strong recommendation with a moderate level of evidence of targeted temperature management was indicated, was recommended in 2020. But in 2023, they said temperature control has to be maintained, but monitor core temperature. And it only strong recommendation is to prevent fever. That's all. It's not about targeted temperature of 32 to 36. They just say you should prevent the fever with a moderate level of evidence, which we as intensivists have largely agreed upon. And this is recommended in both out of hospital cardiac arrest and intra hospital or inside the hospital cardiac arrest. So this is the change, which is a strong recommendation that you don't have to do TTM, you just have to prevent the fever and monitor the core temperature. In 2020, they suggested that if echocardiography is inconclusive or suboptimal, alternate imaging like cardiac MRI should be considered. So it had a moderate recommendation or should be considered 2A with a weak level of evidence. In 2023 also, the evidence, the recommendation remains the same, that cardiac MRI should be considered, may be considered with a weak level of evidence. If echocardiography is not successful in ability to ascertain whether there is LV thrombus and so on and so forth, one has to resort to cardiac MRI. And if there is an ST elevation MI with a multivascular disease, before discharging them from the hospital, in 2017, they suggested even the non-infarct related artery has to be revascularized. So there has to be a stent placement or revascularization of the non-infarct related artery. So that artery may not be involved in the infarct, but if it is significant, that should be fixed is what was meant to be considered. So it should be considered 2A, moderate recommendation with a good level of evidence. But in 2023, it gets a strong recommendation. It says that index PCI has to be done for non-infarct related artery, and this has to be done within 45 days. And this is a strong recommendation with a good level of evidence. 1A is strongly recommended with a good level of evidence. Complete revascularization of the culprit vessels and non-infarct related artery should be done based on the clinical significance, but has to be done within 45 days. So this is a new recommendation. And in 2020, I think this guideline pretty much remains the same, that one should maintain the blood sugar level less than 180 and hypoglycemia should be avoided and should be considered and a good level of evidence. And same thing remains the same, but the level of evidence has been weakened in 2023. So that is about the sort of the difference between 2020 and 2023. We look into what are the new recommendations. So the new recommendation is in patients who have undergone CABG, so dual antiplatelets therapy has to be given for 12 months. You saw after percutaneous intervention, it's 4 to 6 months. Then you stop aspirin and you continue P2Y. But after CABG, dual antiplatelet therapy should go on for 12 months. Strong recommendation, although the level of evidence is weak. In patients with high bleeding risk, so clopidogrel should be considered, and as they said, may be considered 2B with a moderate level of evidence. If patients are event-free, this I've already suggested for 3 to 6 months on dual antiplatelet therapy, they have to de-escalate it to single antiplatelet therapy with P2Y2 inhibitor, and that is moderate recommendation. When I say moderate recommendation, it should be considered 2A, and it's a good level of evidence. And long-term therapy with antiplatelet should be with P2Y12 inhibitor, and which is an alternative to aspirin. Before, I'm sure many of us would like to just continue them on aspirin. Now the long-term antiplatelet therapy is with P2Y12 inhibitor. That should be considered, that is 2B, moderate recommendation with a good level of evidence. And when someone is on oral anticoagulants, if suppose patient has an atrial fibrillation or there is a risk stratification done for anticoagulation. If someone is on oral anticoagulation and on antiplatelets, the antiplatelets has to be stopped at the end of 6 months, and there should be continuation of the oral anticoagulants. So they both should not be continued after 6 months. This is something which intensivists should bear in mind, because very often you see patients coming on warfarin with aspirin. At 6 months, there's no need to continue antiplatelet. One can stop antiplatelet, and that is moderate recommendation with a moderate level of evidence. And de-escalation of antiplatelet therapy less than 30 days, one should not stop antiplatelet therapy. It should be continued for a much longer time, as you say, at least 3 to 6 months dual antiplatelets, and then after that it has to be weaned to single antiplatelet, and within 30 days one should not stop antiplatelet, and that is something one needs to bear in mind. And what about for cardiac arrest and out of hospital? What is the new thing? So one has to put on multimodal neuromonitoring to ascertain the neurological prognosis that gets strong recommendation with a weak level of evidence. And it is suggested or should be considered that if a hospital has no facility for taking care of post cardiac arrest, the patient should be transferred to a cardiac arrest center. That should be thought of, has to be considered, which is a moderate recommendation with a weak level of evidence. So this is for the cardiac arrest. And let us look into what are the suggestions or recommendations for technical aspects of invasive. Suppose if there is a coronary artery dissection, as you see here, when there is a coronary artery dissection, percutaneous intervention has to be thought of when there is ongoing signs and symptoms of ongoing ischemia. If there is an ongoing ischemia in the setting of coronary artery dissection, percutaneous intervention has to be done. Or if there is reduced flow, if the coronary flow is compromised, then one has to consider percutaneous intervention. Or if there is a lot of big area of myocardium which needs to be salvaged, then one has to consider percutaneous intervention. If a big area of myocardium is affected due to the dissection, then one has to consider percutaneous intervention. This is a strong recommendation with a weak level of evidence. And already suggested, intravascular ultrasound, IVUS, has become a norm these days. It has to be considered in a complex sort of a multivascular disease to ascertain the severity and plan appropriate intervention that gets strong recommendation. Not strong, it's a moderate level of recommendation with a good level of evidence. So what about recommendations for multivascular disease in acute coronary syndrome in cardiogenic shock? In cardiogenic shock, staged percutaneous intervention for non-infarct related artery has to be considered, which is a moderate recommendation with a weak level of evidence. And recommendation for multivascular disease in hemodynamically stable STEMI is percutaneous intervention of non-infarct related artery. At least the angiographic severity has to be ascertained. Strong recommendation with a moderate level of evidence has to be thought of. And what are the recommendations for ACS complications? If there is a persistent high degree AV block, even 5 days after MI, so permanent pacemaker has to be thought of. If there are blocks, high degree AV blocks that are prevailing and persisting even after 5 days after MI, permanent pacemaker has to be thought of. Strong recommendation with a weak level of evidence. And this is already suggested if echocardiography is inconclusive or suboptimal to ascertain if there is an LV thrombus, you are not able to make out in echo, cardiac MRI has to be considered, which is 2A and a weak level of evidence. And what about for acute anterior wall MI? If there is an acute anterior wall MI and the apex of the myocardium is not able to be visualized with conventional echocardiogram, contrast echocardiography has to be considered in anterior wall MI where your apex is not visualized. That is moderate recommendation, weak level of evidence. And if there is high degree of AV block which is persisting and there is a risk of arrhythmias, so intraventricular cardiac defibrillator has to be thought of. That it contains, that constitutes moderate recommendations or should be considered to be with a weak level of evidence. If patient is at a risk of arrhythmias in ACS, so some amount of sedation and analgesia has to be considered to reduce the sympathetic drive. One has to resort to using opioids and gentle sedation to reduce the risk of arrhythmias, especially in patients who show signs of intermittent tachyarrhythmias. So this is also should be considered moderate recommendation, weak level of evidence. So now we'll slowly switch gears to move to the recommendations for ACS with comorbid conditions. So the choice of long-term glucose lowering agent has to be calibrated to the other comorbids that may be present, like comorbidities of heart failure. If they have comorbidities of CKD, then the choice of your glucose lowering agent has to be calibrated to the prevailing comorbid conditions, and that gets strong recommendation with a good level of evidence. If there is an elderly gentleman, very frail, with a lot of comorbidities, one has to weigh the risk-benefit sort of a balance before embarking on percutaneous intervention, which as intensivists, we are all very good in doing this. So if this very frail, very elderly, and the risk is outweighing the benefit, one should resort to medical therapy and not embark on putting them on interventions that get strong recommendation with a medium level of evidence. So this is an interesting area which I thought was interesting. If there is an oncology patient whose survival is more than 6 months and has developed ACS, if the patient is on chemotherapy, and oncologist says survival is more than 6 months, then they have to be given the option for percutaneous intervention that gets strong recommendation with a medium level of evidence. And there are many chemotherapy drugs or immunotherapy drugs which can lead to ACS. If those are the drugs which is suspected to be the cause of ACS, they should, and that drug has to be temporarily stopped or interrupted, that gets strong recommendation with a weak level of evidence. And if survival of this cancer patient is less than 6 months with a high bleeding risk, then one should not embark on doing invasive percutaneous. So conservative medical therapy and non-invasive strategy has to be considered, which is a medium recommendation or moderate recommendation with a weak level of evidence. And aspirin is not recommended if platelet count is less than 10,000, and that is not recommended. As you see, it gets 3 with a weak level of evidence. And if clopidogrel is not recommended if platelet count is less than 30,000, and as you see, it gets 3, which means it's not recommended with a weak level of evidence. So for aspirin, platelet count should not be less than 10,000. For clopidogrel, platelet should be more than 30,000. And prasugrel or ticagrelor is not recommended if platelet count is less than 50,000. So this is something useful for intensivists. Less than 10,000, you can't give aspirin. Less than 30,000, you can't give clopidogrel. If it's less than 50,000, you cannot give ticagrelor or prasugrel. So this is something you can keep in back of your mind, which is useful. And what about recommendations for long-term management? Intensifying the lipid-lowering treatment at the time of discharge is strongly recommended. Good level and low level of evidence. So intensifying the lipid lowering has to be incorporated before hospital discharge. And this is something which I found interesting and new. Colchicine, 0.5 milligram per day, is sort of at least should be considered or may be considered in recurrent cardiovascular events, despite all the modifiable risk factors, despite statins and all the other therapies that you would have put in. If there is a recurrence, colchicine could be thought of, and actually it gets a good level of evidence. A is a good level of evidence. So this is something new for us. So colchicine, something to be kept in back of mind. And high dose statin with ezetimibe has to be at least should be considered at the time of discharge if the routine statins have been have had the inability to lower the cholesterol levels. So ezetimibe is something that should be looked at in combination and could be considered. So this is the summary of all the recommendations that came with regards to 2023 for the ACS. So I thought I'll just make a brief mention. This is something that has evolved, but this is not incorporated in ACS guidelines. So in ACS heart failure, the role of SGLT2 has got recommendation from American College. This is something I thought I should touch about. So what are SGLT2? SGLT is sodium glucose transport inhibitors. So what happens is most of your 90% of the glucose is predominantly absorbed from the proximal PCT, from the PCT by the SGLT2, which is sodium glucose transporters. So when SGLT2 and this glucose is absorbed along with the sodium in the PCT, and they move concurrently and together in the PCT, and predominantly these are absorbed in the PCT facilitated by sodium glucose transporter. But when you use SGLT2 inhibitors, this reabsorption of glucose and sodium is mitigated, and in fact there is a secretion of sodium and glucose into the PCT. That's why the use of SGLT2 inhibitors causes glycosuria. So there will be excretion of glucose in the urine. And some of the SGLT2s that are approved is the ones that are commonly used in India, dapagliflozin and empagliflozin, and there are multiple trials that have happened. And canagliflozin, all these are available in the countries that are shown, ipragliflozin, lusiogliflozin, so on and so forth. But in India, we have dapagliflozin and empagliflozin. And the dosage of dapagliflozin is 10 mg once a day, empagliflozin is 10 mg, canagliflozin is 100 mg. But there are certain precautions for usage of these drug. If someone, it has to be discontinued prior to someone undergoing major surgery or someone who has hypotension because it causes natriuresis and glycosuria. And if there is hypovolemia, one should avoid using. And in patients with type 1 diabetes, these SGLT1 inhibitors are contraindicated. Or someone who's had a previous DKA, this is to be avoided. Or someone with a acute kidney injury or CKD where estimated GFR is less than 30 ml per minute, one has to consider not using this SGLT2 inhibitor. And someone with a recurrent UTI, which we commonly see in our ICU, this has to be avoided because this can cause recurrent sort of a UTI. Because there is a lot of sugar in the urine, there is a risk of this patient developing recurrent UTI. And diabetic foot or end stage diabetes where there are diabetic foot complications also, this needs to be avoided. And the Emperor reduced trial is a large trial looking at the benefit of SGLT2, where they showed the risk of UTI was significantly higher in patients who are empagliflozin 1.7% versus 6.6% in someone who was not on. So why we are talking about this? Because ACS related heart failure, this has come as a recommendation by 2022 American Heart Association guidelines for heart failure does recommend that dapagliflozin and empagliflozin should be added on to the armamentarium in patients with heart failure with either preserved ejection fraction or with reduced ejection fraction. This has to be considered. So, and the guideline directed medical therapy for heart failure with reduced ejection fraction now includes 4 medication classes, which may be aspirin, beta blockers, AC inhibitors, along with SGLT2 inhibitor. And SGLT2 inhibitor have a 2A recommendation, which is moderate sort of a recommendation with a good level of evidence in heart failure with mildly reduced ejection fraction. And the new recommendations for heart failure with preserved ejection fraction also, there is a moderate recommendation with a good level of evidence. So American Heart Association does recommend incorporation of SGLT2 in ACS related heart failure along with all the other dimensions that you would have put in place. So those are all the newer changes that have come in our 2023 guidelines and a bit of a mention of SGLT2 inhibitors. So I invite you all to our signature conference JICS that's happening in October 18 to 20th in Bengaluru. I invite you all to attend this and request you all to submit your valuable work to Journal of Acute Care, and you can visit my website to rehear to this lecture. So thank you one and all.